Welcome everybody to our episode today. We're so excited that you guys are joining us. We have a special guest today. This is Dr. Wolf.
Hello.
She is a radiologist from the Integris Comprehensive Breast Center here in Oklahoma City. We are so glad that you could spend some time with us today.
I'm glad I'm here to talk.
So we're going to talk about all things imaging today. So I have a couple questions here for you. We just thought that we would go through these, but let's start off. What's the difference between a 2D and a 3D mammogram?
Okay, so a 2D mammogram is kind of the original mammogram, and it is an image where we take a single picture of the breast tissue, and we do that in 2 dimensions. So if anyone who's had a mammogram out there can probably remember that we press top to bottom of your breast, and then we press it side to side, and so we take 2 2D images of each breast. Now, as a breast imager, when you look at that image, you're seeing the breast tissue piled up on itself. You see all of the breast tissue in one image, and so you just see everything piled on itself. In contrast to a 3D mammogram, we're still pressing you the same way, top to bottom and side to side, but instead of just taking one picture, the mammogram machine actually moves in an arc around your breast, and it takes several 1 millimeter slice pictures of your breast. So depending on how thick of a breast you have or the size of your breast, we could end up with 25 pictures of that breast or 65 pictures of that breast, but it's multiple pictures, 1 millimeter slices through the breast. And it really helps us to look through that breast tissue. Because instead of just looking at it all piled on itself, we're actually sort of driving through the breast tissue.
Okay.
And that gets really important, especially in people with dense tissue. And I think you have a question later on about that, but and how that 3D mammography really helps us see through dense tissue.
So is the 3D, is that the standard now, or is that something that we should be asking for?
So in most big institutions, most big breast centers, it's probably the standard, but some smaller places may just still have 2D. And if you have dense breast tissue, it is really a benefit to go and get your screening at a place that has a 3D capability. The studies show that 3D mammography increases the detection of breast cancer across the board, no matter if you're dense or not dense, but it especially helps detect it in people who are dense.
How do we know if we're dense?
So if you're dense, you're going to get a letter on your screening mammogram that tells you.
Okay.
So that is a state law requirement that started several years ago.
Good.
That we have to notify everybody about their density. And so you'll get a letter that says, you are dense, and you might want to talk to your doctor about it.
So make sure you guys are looking at your scan so you're aware of what your tissue is. Because I know a lot of times we're not paying attention, or we don't understand necessarily the ramifications of what dense means. So you might just be aware of that, because you'll want to be looking at some maybe dual modalities and things like that. Okay, walk us through what to expect after a woman gets a call about an abnormal mammogram.
Okay. All right, so when we call you back from a screening mammogram, it's because we notice something. And there could be so many things we notice. We might notice an area that's more white on your mammogram, or we might notice a new mass or a new calcification. There's so many things we're looking at when we are reading a mammogram, and really we're looking for changes. So any little change on a mammogram, we're going to call you back for. The majority of times you get called back, it's going to end up being nothing. It's going to be something that we're able to dish out and figure out while you're there. Of course, some of those times you're going to get called back for something that's suspicious, and that's the whole reason you're having your mammograms. But when you get called back, we will either use mammogram or ultrasound or both to figure out what's going on. So sometimes you may get called back and go right onto ultrasound because of the finding. Sometimes you may start with mammogram. Sometimes you may get a mammogram and the problem is solved and you don't need the ultrasound. Mm-hmm. So we can use both modalities, and those are going to be the 2 things that we use to figure out the problem. Mm-hmm. And in most places, at least definitely at my breast center, you don't leave that callback without seeing a doctor, without seeing the radiologist. So you're going to to get the imaging you need, and then the doctor is going to come in and tell you, this is what this is, and this is the plan. Either you go back to your screening next year, or we need to do X, Y, or Z.
Okay.
Now, it may not be, I can't speak for all breast centers as far as that sort of workflow, but
Mm-hmm.
I think that's how it is at most big areas. That's how it is at CBCO.
Okay. Awesome. Now, if you're a woman under 30 and you feel a lump, what should they expect?
So I imagine probably you'll tell your doctor, and then your doctor will send you to a breast center. You could always call a breast center too if you feel a lump and you don't have a doctor. But under 30 years old, we will generally start with ultrasound first.
Mm-hmm.
We may use mammogram if we need to, but usually the first step, if you are under 30, so if you're 29 or below, is going to start with ultrasound.
And so, okay, I know for me, I was 25 when I found it the first time, but I was kind of dismissed, and I had to be insistent about my own care. And when I went back the second time, they still were like, no, it's nothing. And we really had to push to be able to get a referral
To
be
a breast
able to
center.
go. Yeah.
Yeah.
So,
Yeah.
Do you have any
If you
advice
feel
about
a
that?
lump, I would be insistent.
Okay.
Be insistent that it get checked out. A doctor can feel and examine you, and that's great, but if you're feeling a lump, it should be imaged, and somebody should put an imaging, should use imaging to determine
to see
if
what's
it's
going
okay.
on, right? And we need to advocate for ourselves. We talk a lot about that, ladies, and you know your body better than anybody. So I agree with Dr. Wolf. Make sure you get it checked out. Okay, if a woman's high risk of developing breast cancer, what should she expect for the screening?
Okay. Risk is calculated based on a variety of different characteristics. So a lot of our risk is based on our genes, on our family history, and so a lot of the weight in calculating your risk is going to be on who in your family has had breast cancer and how close they are to you and what ages they were when they were diagnosed. But also other things go into your risk, like when you started your period, how old you were, how many babies you've had, how long you've breastfed, have you been on birth control pills, have you taken hormones, all kinds of things like that. Your density even goes into your risk calculation.
Okay.
And so right now, I don't want to get too scientific here, but the most widespread risk calculation that we use in breast imaging is something called the Tyrer-Cuzick risk. And if you are 20% or higher, so if that means that if we calculate that you have a 20% or higher chance of developing breast cancer in your lifetime, you're considered high risk. And that changes how we screen you. Depending on how young or old the people in your family were with breast cancer, you may need to start screening before age 40. And you may need MRIs every year in addition to mammograms. All of that kind of just depends on your history, what your actual score is, and depends on you. And so it's a conversation that your breast imaging doctor and your doctor have with you on what you need to be doing and when you need to be starting. But in general, high-risk people get a mammogram every year and a breast MRI every year.
Okay, as you're saying this, it's making me think about all of us, pretty much are survivors, I'm assuming a lot of us are, and a lot of us have daughters.
Yes.
What should that protocol look like? I know my daughter is just turned 16, and I was 25 when I found it. What do I do with her?
So, one question we would ask first too is your gene status. Like, were you positive for any gene mutations? Okay. And you were diagnosed at 25.
Yes.
So her risk is going to be elevated because you were so young. She should start screening at age 25 with MRI.
Okay.
And then when she turns 30, she would start her mammograms as well.
Okay.
We don't use mammogram as a screening tool until you're 30 and above. And the reason is because it is radiation. Mammograms are radiation. They're very, very low dose. They do not cause breast cancer. But we like to protect the breast tissue as long as
you can.
Yeah, as when that benefit starts outweighing the risk, then it's time to start the mammogram. And so 30 is about what the study shows about the right age to start mammograms if you're high risk.
Okay.
And then before that, we use breast MRI, which has no radiation. It uses magnetism.
Okay, well, we have some friends that I know that are BRCA positive,
Mhm.
and they have had their daughters tested.
Mhm.
And I know for one, now she just turned 16 and she is BRCA positive. What does that look like? Will she start screening now?
So same guidelines for her as would be your daughter. She would
Okay.
start breast MRIs at age 25.
Okay.
And then start her mammograms and MRIs at age 30.
Okay.
Mhm.
That's good.
Yep.
Okay, from a survivor standpoint, what surveillance should we expect?
Okay, that depends on what kind of surgery you've had. So we can kind of go through all of the different scenarios. If you've had a bilateral mastectomy, and it's not a nipple sparing mastectomy, it's a true bilateral mastectomy, you don't need image screening. You definitely need to do yearly breast examinations with your doctor or surgeon if you still see him, and yourself, but you don't need breast imaging if you've really had mastectomies. If you've had a lumpectomy, so you've had the cancer removed, but the rest of that breast is still there, and the other breast is still there, then for the first 2 years after your surgery, you're going to be imaged more closely on the side you had cancer. And usually that looks like a mammogram every 6 months for 2 years. And then after 2 years, we put you back to a normal yearly screening mammogram. If you've had a mastectomy on the side with cancer and the other breast is there, then you're going to screen that breast normally every year.
Okay.
There's kind of a new caveat that has come out recently from the ACR that shows that people who are diagnosed under the age of 50 benefit from screening MRIs every year too, kind of like high-risk people. And so that's something that we have instituted here just in the last year because of the research from the ACR. And so we treat them like high-risk people, and they get a mammogram every year and they get a breast MRI every year if you're diagnosed under age 50.
Now, when you say imaging, you're meaning a mammogram, because like those of us that have double mastectomy, we do MRI.
And some people still do that, but it's not a concrete recommendation.
Okay, now what? Okay, so a lot of us do reconstruct and some of us don't. Depending on is it dependent on what type of reconstruction you've had?
Yeah.
Because I know I've had implant reconstruction, and that's why we image for that, to look at those.
Yeah, and like, I don't know if you probably have had silicone implant.
Yes.
Yeah. And so it's important to look at those every couple of years to make sure that
The integrity of,
and everything. So, and actually now even just people who haven't had mastectomies who just get augmentation, it's recommended, I think, by the College of Plastic Surgeons that you get an MRI every 2 years,
really?
just to look the
Make sure
integrity.
it's okay.
If it's silicone, saline, you're going to know if it ruptures because it just deflates, but silicone implants can be sneaky, and sometimes you can't detect the rupture, and so those get imaged.
Now, what about, I'm thinking as you're talking, what about people who've had flap surgery, like deep flaps? That's still their own tissue.
So that's tissue, like from the abdomen?
Yes,
Yeah, so they still don't need mammograms. Some people get MRIs to screen for that because there have been a few cases where breast cancer can come back in the flap. And so MRI is a great way to screen for that. But the recommendations aren't real concrete on, yes, we have to do this on everybody. And so I think a lot of people do it and a lot of surgeons order it, but there aren't real concrete recommendations on it. But the best way to screen for that would be MRI.
Okay. Now, I know for me, guys, like I continued, even though I'd had reconstruction the first time, double mastectomy the first time, I still continue to do self-exams, even though I had had the mastectomy. So I'd encourage you guys, and even with the flap surgery too, even if you're flat, you still should be doing your self-exams. All the way up to your clavicle, under the arm, because I know mine was on my skeletal wall the second time. I thought it was scar tissue, but it was actually a different cancer. So continue to do your self-exams, regardless if you've had reconstruction, no reconstruction, whatever kind of surgery.
And know how your post-operative body feels, because you're going to be the expert on how your body feels. Your doctor may do your exam every few months or year, but you're there being able to feel your body the best.
Well, and then when you were talking to, I know for me, I had a fat graft, and some of it had calcified, and so it formed a lump up here, and I thought it was another tumor, and I just called my imaging center, and they got me in immediately, and they could tell right away. They did an ultrasound, and they knew it was fat. So, but like she said, we need to be aware of our body, so we know of any changes that happen. Okay, let's move on. Let's say, what are the different ways biopsies can be performed?
Okay, so we can do biopsies basically using any of the three main breast imaging techniques. So we can do biopsies with mammogram, and generally when we do those, it's for calcifications, when we see calcifications, because those are best seen with mammography. But sometimes little asymmetries or even some little masses are better seen with mammography. So we can target with mammogram. We also use ultrasound to do biopsies. And we can even use breast MRI nowadays to do biopsies. So we do the biopsy based on the modality that best shows that lesion.
Okay.
And that's because we want to make sure that we're biopsying the thing that is most suspicious.
Okay.
So if we see something on a mammogram and we go to ultrasound and say, oh, well, I think this is the ultrasound correlate, that's not good enough. You want to make sure that you're biopsying by the modality that you see it best. So any way we see something, we can biopsy with those modalities. You know, sometimes people get nervous if there was a finding on the mammogram that's suspicious, but we can't find it with ultrasound. It doesn't matter. We can still target the right thing using any of those modalities.
So once you determine what modality you're going to use, so let's say it's ultrasound, how do you determine whether you're going to do needle, punch biopsy? Like, are there more ways to do it than
No,
needle?
we do only core needle biopsies. So every biopsy is a core needle biopsy. Punch biopsy is a type of biopsy we can do of the skin if there's a suspicious, if we think skin is involved or something.
Okay.
But breast biopsies are all core
okay.
needle, which means it sounds big, but core needle biopsies are usually like, 14 gauge or 12 gauge. They're little tiny snips of tissue. We don't need very much to make a diagnosis, but they're all core.
Okay. All right. Now, if a woman's waiting on her appointment to go over her biopsy results and her imaging report pops up in her patient portal and says BI-RADS 5, what does that mean?
BI-RADS 5 is our international nomenclature for breast, one of our international nomenclatures for breast imaging. BI-RADS 5 means highly suggestive of malignancy. So it's a very suspicious finding. It would be something that would definitely be biopsied.
Okay. Because I know a lot of times now, especially because we do have patient portals, we get on there because we're so anxious and want to know. I think that's good to know. So what should they do should they call you immediately, or should they just wait for the call?
Well, at least in our institution, we are going to have counseled the patient that they might see their result before you get called, that you will be called. We call the same day results come out, and so the patient knows that even if they see it, they're going to be called. Now, if it pops up at 11:30 at night, obviously it's going to be the next morning.
Right.
But that's our workflow here, is that our nurse navigator calls every patient with their results. Yeah, and that's a biopsy result. Now, if you see a BI-RADS 5 from your the consultation that you've just had, I would assume that the doctor had talked to you about doing a biopsy then. At least that's how the workflow would happen here, because diagnostic patients see the doctor, and so the doctor has sat down with them, said, I see something really suspicious on your imaging, let's schedule a biopsy.
Okay.
And then that report with the BI-RADS 5 would come up on the portal, so at least here they would already be expecting something suspicious. Yeah. Okay.
That's
good
to know.
Of course, I don't know how other places do it, so there may be places where you would see that. And in that case, I think calling your doctor would be important if you haven't already been, if it hasn't been explained to you.
Yeah. But there's a lot of terminology that we're not aware of, so I'm glad that you explained that to us, because we see these words and it's like foreign language.
Yep, and BI-RADS is just kind of like, it's just a nomenclature we use so that across the board in all states, and we're all kind of talking with the same language to each other as far as breast imagers go, and to clinicians, so they understand the degree of concern for findings.
Makes sense. Okay, if a patient's been told that they have dense tissue, which we talked about before, what does that mean?
So, tissue density basically just means the ratio of fatty tissue you have to the more fibrous fibroglandular tissue in your breast. We all have different ratios of it. So our breast tissue is made of fatty tissue, which shows up more dark on a mammogram, and it's made up of fibroglandular tissue, which shows up more white on a mammogram. So the more fatty tissue you have, the darker your mammogram is, so the more black it is, and the more easy it is to read. The more fibrous tissue you have in your breast, so the more dense you are, the more white of a mammogram you have. And so when we're looking for cancers, oftentimes cancers show up as white areas or white asymmetries in the breast. And if you can imagine, if you've got a very white mammogram and you're looking for something white, it's kind of like looking for a cotton ball in a cloud, right? It's difficult to see.
Mm-hmm.
Whereas if you've got a mammogram that's very black and you're looking for something white, that's going to be easier to see. And so that's why breast density changes how easy it is to find something on a mammogram. And that's why things like 3D have been developed, because we know in very dense tissue things can hide. Not because the breast imager is bad at what they do or anything like that, it's just that it can hide because you've got a different type of breast texture and density. Mm-hmm. And so we know that it's harder to find cancer in dense people, and that's why this process of notifying people of their density and things is so important. The best thing that you can do with dense tissue is make sure you're getting tomosynthesis or 3D mammography. Make sure you're going somewhere where they can do that, mm-hmm. because that's how we see through the tissue best. There are things like screening ultrasound that can also be used as well, like other types of screening modalities that can be used. Sometimes breast MRI is even used. The problem with ultrasound and MRI right now is that a lot of it is not covered by insurance just because you're dense. And hopefully that changes, in our government and things as time goes on. But across the board, we know that tomosynthesis works, and it really helps increase the detection of breast cancer in dense people. And so at least make sure you're doing that. That mm-hmm. will really, really help us. I kind of explain it to people like, if you were looking for, I don't know, a landmark or say a little civilization in a jungle, and you're up in a helicopter or a plane looking over this dense jungle, it's going to be difficult to see something underneath all of that, mm-hmm. that the trees and the ivy and the brush and everything. But if you got into a Jeep and started driving through that jungle, it's going to be easier to find what's in it. And that's kind of what tomosynthesis is like. When you're able to get all of those little 1 millimeter slices of the breast tissue, we essentially are driving through the breast tissue.
That's good.
And we can see if there's something in there. The really awesome thing about tomosynthesis too is that not only does it increase detection of breast cancer, it decreases false positives and it decreases false callbacks. And so when an area of the breast tissue is maybe lined up on itself and it looks wider or mm-hmm. more thick, not because there's a tumor there, but because the tissue's lined up funny, when we use tomosynthesis, we can discover, oh yeah, that's not a tumor, that's just the breast tissue lined up. And so what we may have called back using just a 2D mammogram wouldn't be called back if there's 3D there. So it was really just an amazing thing to come out, because it was one of those tests that both increased sensitivity and specificity. And a lot of times that doesn't happen. You lose one or the other. So it's just such a beneficial thing for people across the board, whether they're dense or not, but especially if you're dense.
That's awesome. At the end of the day, though, ladies, again, you need to make sure that you're advocating for yourself, that you're staying on top of your exams, regardless of what type of tissue you have, but especially if you have dense tissue. So thank you, Dr. Wolf, for being with us today. I really appreciate it. So if you guys are enjoying these episodes, please like it and subscribe to our channel. And also, if you'd like to get more involved, if you really need more of a community, feel free to get on to project31.com. We have different groups throughout the month that you guys can subscribe to or come on and join us. And then if you'd like to listen to our podcast as well, go to Pink Ribbon Roller Coaster on your podcast modalities, and you can listen there as well. So thanks for joining us. We'll see you next time.